Good day, I am Dr. Teke Apalata, a clinical microbiologist, and today we are going to continue with the second part of our lecture on bacterial respiratory tract infection. So let me just share my screen with you. So we started yesterday a lecture on respiratory tract infection, and we discussed the first part that dealt with viral respiratory tract infection, and today we will continue with bacterial respiratory tract infection. Once again, I am Dr. Teke Apalata, a consultant in clinical microbiology. So, the bacterial acute respiratory tract infection can be divided in two main parts. We have bacterial upper respiratory tract infection, and we have bacterial pneumonia. And the bacterial pneumonia, we will subdivide these in three parts. We will discuss community-acquired pneumonia, hospital-acquired pneumonia, and atypical pneumonia. So this is the classification that we are going to follow. Let's look at bacterial upper respiratory tract infection. And the first condition is what we call pharyngitis, bacterial pharyngitis. So bacterial pharyngitis is caused by a number of pathogens. And then the commonest one, we have a Streptococcus pyogenes, or group A Streptococca, that we call Streptococcus pyogenes. We have also group C and G beta hemolytic Streptococca. We have a mixed anaerobes. We also have Neisseria gonorrhea, especially with a patient who have oral sex. Then they can also develop a STD that is caused by Neisseria gonorrhea, pharyngitis associated Neisseria gonorrhea. We also have a Corynebacterium diphtheriae and Yersinia enterocolitica. So those are the commonest causes of pharyngitis, bacterial pharyngitis. Then we have a subset of pharyngitis, of bacterial pharyngitis, that we call Lemierre disease. We call it Lemierre disease. So Lemierre disease begins as a pharyngitis. It's caused by Physobacterium necrophorum, and after that, it becomes an acute septicemia with findings that are similar of jugular vein thrombosis. So we call that condition Lemierre disease. We have another subset called quinsy. Quinsy, it's a peritonsillar abscess. It's a peritonsillar abscess, so it is a complication of streptococcal pharyngitis then with a mixed anaerobes involved. So it starts as a pharyngitis caused by Streptococcus pyogenes, then it becomes superinfected with mixed anaerobic bacteria, so we call it quinsy or peritonsillar abscess. Then the second condition is acute otitis media. So the causes of acute otitis media are the same causes of community-acquired pneumonia. So when we will discuss community-acquired pneumonia, you will remember that the same causes of community-acquired pneumonia are the causes of acute otitis media. So just follow in a minute, we will discuss community-acquired pneumonia. Then we have acute bronchitis. Remember, when we discussed the lecture on viral respiratory tract infection, I said that acute bronchitis are mainly caused by viruses. So non-viral agents that have been implicated include in acute bronchitis mainly include Mycoplasma pneumoniae, Chlamydia pneumoniae, Bordetella pertussis, and Bordetella parapertussis. So those are the only bacteria that are able to cause acute bronchitis. But when you have a patient with acute bronchitis, it's mainly a viral condition. So although causes of acute otitis media and community-acquired pneumonia, so the causes involve Streptococcus pneumoniae, Haemophilus influenza, and Moraxella catarrhalis. Those are the causes of community-acquired pneumonia, and they are also the causes acute otitis media. So we say that although those cases, those causes of acute otitis media and CAP are key players in exacerbation of chronic bronchitis, there are no data to suggest that they are important pathogens in uncomplicated acute bronchitis. So they really don't play any major role in acute bronchitis. Okay. Now, community-acquired pneumonia, we already say that the commonest causes are streptococcal pneumonia, Haemophilus influenza, and Moraxella catarrhalis. Now, what is now the pathogenesis of bacterial acute respiratory tract infection? First, let's understand the pulmonary defense system, how it works, the normal pulmonary defense system, because the breakdown of this defense system will then lead to the condition that we see, the bacterial respiratory tract infection. So the first defense system includes anatomic and mechanical barriers. So here we have a ciliated epithelium that play a major role, and a mucus producing cell in the respiratory tract. They play a major role in preventing those bacterial infections, and they play a role in the clearance of entrapped microorganisms. And we also have a humoral immunity, mainly the immunoglobulin A that we found on the respiratory mucosal lining. They possess antimicrobial activity at the mucosal surface level. So they play a major role in killing some of the microorganisms. And we also have alveolar lining fluid like surfactant or fibronectin, IgG, and complement factors that we can find in the mucosal surface of the respiratory tract system. Then we also have cell-mediated immunity, and it's important against pathogens that are able to survive within the pulmonary macrophages. Antigens are presented by antigen-presenting cells. Then there is an activation of lymphoid cells with a migration of memory lymphocytes who will come at the site of infection, and they are able to play a major role in preventing the occurrence of bacterial infection. Then we also have the phagocytic the activities of the phagocytes. So like in the lungs, we have alveolar macrophages and the neutrophils that can be recruited when there is a problem, and they prevent the development of infections. Then we have now impairment of these pulmonary defenses. The pulmonary defenses can be impaired. And what are the reasons for the impairment of the pulmonary defenses? One of the things that can happen is what we call alteration in the level of consciousness from any cause like stroke, seizures, drug, or maybe alcohol intake, excess alcohol intake. It can compromise the epiglottic closure and lead to aspiration of oropharyngeal flora now. So if there is an alteration of the level of consciousness, then all the microorganisms that are normally found in oropharyngeal area can be swallowed, aspirated. So they can go into the respiratory tract, and they will cause what we call aspiration pneumonia. There is also the same with people who smoke cigarettes. Cigarette smoke, viral infection, they may destroy the epithelium lining, and interfere with the ciliary activity. So when you are a smoker, or when you develop a initial viral infection, it will destroy the ciliated epithelium, of the mucosal surface on the respiratory tract. Then you can develop a bacterial infection. If there is also defect in the T cells, like in HIV infected patient or patient with malignancies, we can have a defect in the mechanism of the T cells. So you will see that most of those patients will develop respiratory tract infections. Potential pathogens for lower respiratory tract infection are among commensals, which, you know, in the presence in a respiratory tract can be intermittent or permanent, depending on the age, location, socioeconomic status, and vaccination status. So some of the pathogen can be there among the oropharyngeal normal flora, and they might be time to time be able to cause an infection, depending on the age, whether you are too young or too old, whether you are not vaccinated, or socioeconomic status, like poverty. Then pulmonary impairment will allow these commensals then to cause an infection. So this was what we have discussed so far. Now let's look at hospital-acquired pneumonia. We discussed community-acquired pneumonia, then the hospital-acquired pneumonia. There are many microorganisms, mainly gram-negative bacteria and gram-positive, that are able to cause hospital-acquired pneumonia for patients who are admitted in the hospital setting. Among the gram-negative, we have Pseudomonas aeruginosa, Enterobacter species, Klebsiella pneumoniae, Acinetobacter, and other pathogens that we can see. And among gram-positive, we have mainly Staphylococcus aureus, but we can also have Streptococcus pneumoniae. We have anaerobes, we have fungi, you know, like Candida, and sometimes we have patients who develop mixed infection. Now, what happens especially is that this is the respiratory tract, this is the trachea, and especially patients who are intubated, who are under mechanical ventilation, they are in intensive care unit. So you can see that the tube is placed. This is an endotracheal tube that is placed. Then you have what we call biofilm. Biofilm is actually a microorganism that are coated on the surface of the tube, and they down-regulate their metabolic pathway. They form a biofilm, they attach there. Then from there, they change their metabolic pathway. Even if you give an antibiotic, it's not going to be able to kill them within the biofilm. So what will happen is that if one microorganism from there passes into the lung, then from there it's going then to cause an infection. So that is how hospital-acquired pneumonia, especially in patients who are ventilated in intensive care unit, that is how it happens. So the same microorganism you find in the biofilm, it's what you are going to find here, causing pneumonia. So that's why time to time, the tube should be removed, you know, to avoid that. Then the third subcategory is what we call atypical pneumonia. And atypical pneumonia, those pathogens have been known to cause atypical pneumonia. Initially, when only gram-stain technique was used to make the diagnosis of bacterial infection, those microorganisms were not being able to be detected, like your Legionella, your Mycoplasma, your Chlamydia, Bordetella, Coxiella. So it's very difficult to make the diagnosis using a gram-stain. You know, it's only later on that they were detected. So at that time, they were called atypical. They were also called atypical pneumonia because of the discrepancy that exists between the clinical presentation and the radiological finding of the patient. So you will see that the patient will present with mild clinical presentation, but when you do radiographic chest X-ray, you will find that the patient has much more severe lesions that are not corresponding with the clinical presentation of the patient. So the definition of atypical, it's atypical because of the diagnosis, you know, when using gram-stain, when you rely only on the gram-stain, those were not clear cut-off microorganisms according to the Gramston result. And it's also atypical because of the discrepancy between clinical and radiological findings. Now, we have also pneumonia in the immunocompromised host, and we have mainly pneumonia caused by pneumocystis jirovecii. That is also a much more severe condition that we can see in HIV infected patients. Now, in terms of specimen for laboratory diagnosis of pneumonia, you can have a sputum specimen, and we have two types of sputum specimen. We have what we call expectorated sputum, and we have induced sputum. So expectorated sputum is what the patient can be able to cough out him or herself, and induced sputum where some techniques need to be used, maybe by physiotherapists, to try to induce that sputum from coming out. Then another type of specimen we can have, it's what we call bronchoalveolar lavage. We also have a protected brush specimen. We have transtracheal aspirate. We also have lung biopsy that can be done. So those two, the first two sputum, whether expectorated or induced, and bronchoalveolar lavage that we call BAL, are contaminated specimen, because when it comes from the lung, our lungs are supposed to be sterile. Then when they come out, you cough them out. The specimen come out through the oropharyngeal area, they become contaminated. So those are contaminated. But the protected brush, the transtracheal and lung biopsy are clean specimen. Okay, now let's look at the expectorated sputum. So how to differentiate between causative organism and contaminated? Because when you ask a patient to cough, then the sputum is coming out from the bottom of the lung, and in the oropharyngeal area, it becomes all contaminated with the oropharyngeal flora. Now you need to make the difference between the causative pathogen that really causes pneumonia and the contaminant that is coming from the oropharyngeal area. So that's why the interpretation of this result becomes very important. So let's look at this. This is the epithelium lining of the respiratory tract. Now, let's say that you have a microorganism there that is moving, and we call that Haemophilus influenza. So it's attached or it's trapped by the ciliated cells. Now, this is able to invade despite the mechanism of resistance. It's able to invade because it has fimbriae, it has adhesins that can be able to attach to the ligands of the ciliated epithelium. So it is able to invade this. Then on the bottom, you can see that there are immunoglobulins that are released, that are released there. So those are immunoglobulin A that are released. Then to try to contain the infection. So then from there, we also have other cells that are coming at the site of infection. Those are your neutrophils, okay? Then the neutrophils and the immunoglobulin will progress to come and try to fight Haemophilus influenza. They will then try to fight Haemophilus influenza. So those are all that you will see in a properly taken sputum specimen. So you expected to see the bacterial pathogen, you expected to see the neutrophils, especially a lot of neutrophils that are coming at the site of infection. So that's when someone is coughing, it's what will come, from the bottom of the lung into the mouth. So this is what will come as a sputum. Now, we say that when it's coming out of the oropharyngeal area like this, it becomes contaminated. This sputum, it will become then contaminated with those large epithelial cells that we found in the oropharyngeal area. So this is what came from the bottom of the lung and this is the contaminant that, surround that specimen. Okay, so this is what you find, so mainly from the saliva. Okay, then what is next? This is, those are the squamous epithelial cells. And when you see a lot of squamous epithelial cells, this is a marker of contamination. So when we analyze a specimen, we need to find out how many epithelial cells are found and how many neutrophils are there. Because if we have many neutrophils, it's a marker of a true infection. But if we have many epithelial cells, it's a marker of contamination. So we need to balance the ratio between neutrophils and epithelial cells and the presence of pathogens to try to make the diagnosis of a true infection. So the problem, as I said, is then to be able to differentiate between causative agent and contaminant. So when we do a gram-stain microscopy, there are two methods that we can use. One, we do sputum washing, or we do a Bartlett score to try to resolve this problem. Now, sputum washing is that we have the sputum, we put it on a plate, then we try to wash. When you do the washing, you remove actually the epithelial cells that are there. Then you try to reduce the amount of contaminant. You remain with the true sample specimen that is coming from the lung that you are going to assess under the microscope. Or you do a Bartlett score. If you cannot do the washing, then you look at the ratio between neutrophils and epithelial cells. So if the ratio is 5 or above, then this is a marker of good quality specimen, and it is a marker of a true infection because you have more neutrophils than you have the epithelial cells. But if you find more epithelial cells than you have the neutrophils, then it is a contamination or it is a bad quality specimen. Okay. The other specimen is what we call induced sputum. Now, induced sputum is only suitable for the diagnosis of mainly chronic conditions like tuberculosis that we are not going to discuss in this lecture, pneumocystis pneumonia, cryptococcal pneumonia, or histoplasmosis. Otherwise, it's not a better specimen or looking at acute bacterial respiratory tract infection. So it's not suitable for bacterial infection like staphylococcal pneumonia or streptococcal pneumonia or Klebsiella infection. It's not an appropriate specimen. Then we have what we call bronchoalveolar lavage fluid. So the BAL specimen, the problem with the BAL specimen is that it's a diluted specimen. So it means that when you inject some sterile cell line and you aspirate, you do the lavage, so the specimen become a bit diluted. So it's not going to give you a true reflection of what is actually happening. And it is also a contaminated specimen. We also have a non-bronchoscopic BAL specimen. So this is just a fishing experiment. And the better one is what we call a bronchoscopic BAL, because this you can be able to collect the specimen using a bronchoscopy. You can be able to target the site of inflammation so that you are able to collect the specimen. We have another specimen that we call a protected brush specimen. This is the brush. You see that it's protected. You insert it into the respiratory tract. Then from there, you then push the brush. So it's open up, then it is able to collect the specimen and come out. And it's then protected and you take it out. This is what we call a protected brush specimen. We have also transtracheal aspirate and transcutaneous lung biopsy. Those are much more tedious procedure specimen to take. So the most important specimen to remember is also specimen for pneumonia in patients who are ventilated, who are under mechanical ventilation, who are in intensive care units. And the most important one is what we call endotracheal tube aspirate, ETA. You can also collect BAL, we spoke about that, or protected brush or lung biopsy, but the most important one is what we call endotracheal tube aspirate. So what happened is that we come back to this. This is the respiratory tract, and you have the tube that is inserted, the endotracheal tube. So those patients in intensive care unit are intubated, then they form a biofilm, so the microorganisms are there. So the microorganism will go down. It is able to cause a pneumonia. We have spoke about this. Then, so the aspirates, when you put some, you introduce some cell lines here and you aspirate. You aspirate, then it gives you, so those are the pathogen, and this is the chest X-ray. Chest X-ray of the patient. It's showing an image in of a 49-year-old woman